first researcher to try to provide some validation to manipulative therapy was a physiologist named Irvin Core. Irvin Core was a professor in the physiology department at Michigan State University back in the 1940s and 50s, 60s. He was called by an osteopath named Denslow, Dr. Denslow, who worked at Kirksville, Iowa, and was invited to come to the osteopathic school in Kirksville to see what they were doing in the area of manipulation. So Dr. Core went with the idea that he would be kind of staying for a couple of days and kind of observe what the osteopathic physicians were doing. So he got there and he said, well, what is this all about? And Dr. Denslow said, well, what we're trying to identify is the osteopathic lesion. Of course, that osteopathic lesion, is a lesion in your profession somehow? What does that mean? What is an osteopathic lesion? So we called one of the students over, Dr. Denslow, and Dr. Denslow palpated up and down the back and found a segment and said, there's one right there. Core was about to leave at that point. This is kind of a Ouija board assessment of osteopathic lesions. So what exactly does that mean? How do you know that that's an osteopathic lesion? And Denslow said, well, because it feels different. So Core was trying to, well, how does it feel different? Why do you call this an osteopathic lesion? So Denslow then applied some pressure to that segment, and the student said that was tender. And he said, well, the osteopathic lesion on those particular segments, that one is more sensitive than the others. That's one of the things that I noticed. He says, well, is that something that you can do predictably? Is that something that you, and so Core set up just a small little experiment where he would apply pressures to various increments to spinous processes and determine when the students were going to respond. And so he'd start by applying a 1 kilogram force and then a 2 kilogram force. It would take him like 45 minutes to determine what segments were responding, whereas Denslow did it in like less than a minute. And he also determined that Denslow was quite reliable, that he was consistent in terms of what the instrumentation was showing. So that got his attention. He said, well, is there any more to it other than the fact that the segment is tender? He said, well, I also palpate the surrounding tissue. And there are certain things about the tissue system that also indicate that this is an osteopathic lesion. Well, the osteopathic lesion ultimately became known as a facilitated segment, facilitated motion segments. And the definition of a facilitated segment, as identified by Irvin Core, is a spinal segment which is hyper-responsive to afferent impulses from somatic, autonomic, and central nervous systems. And so this is a hyper-excitable, hyper-responsive segment that's influenced by all degrees, all directions of stimulus from the body's somatic tissues, from visceral structures, and from the central nervous system. He said that the facilitated segment is a neurologic lens in which afferent impulses are focused, then amplified, and then channelized through efferent nerves back to the targeted tissue supplied by the segment. So the segment is hyperresponsive, but it sends back activity into the tissues that it innervates. In essence, the facilitated segment is a hyperexcitable segment that shouts back at its innervated tissues rather than conveys impulses in an integrated manner. And these would be the clinical manifestations of the chronic facilitated segment. First is a temperature difference. And this temperature difference is typically 1.5 to 2 degrees centigrade, which was measured by either thermocouples or thermography. In the chronic facilitated segment, the temperature local to that segment typically decreases. So it's a cooler area. There's typically also increased sweat gland activity, and that was measured through electrical skin resistance, which was lower in that region. There's vasomotor reactivity with respect to red responses is less of a red response. So if the skin is irritated through what we call the scratch test, the skin will have less of a red response, and the red response goes away faster. The increased muscle tone and less extensibility in the related tissue. There's a lower motor reflex level, threshold level, and typically a twitch response or a jump sign. So that's what Cora had initially identified, that these students were responding at certain levels quicker than others. There might be increased sensitization to stimulus at other spinal segments and some evidence of wind-up, where not only is the segment sensitized, but it remains in a state of sensitization after removal of the stimulus. Palpatory findings might also include changes in the ligaments. Oftentimes associated with facilitated segment, that the ligaments either seem to be thinner or thicker. And the ligaments are also sensitive. Oftentimes there were positional faults associated with the facilitated segment, and when they evaluated segmental motion, there was impairment in the movement, either hypo or hypermobile. So I want to take you through kind of a layer palpation sequence, starting superficially at the skin, subcutaneous, muscles, ligaments, vertebra. Okay? And keeping in mind all the clinical features of a chronic facilitated segment, we're going to see whether we can identify facilitated segments or segments that are more sensitized than others. By palpating skin temperature, evaluating to see if there's any alteration in sweat gland activity, assessing vasomotor reaction by doing a standardized scratch test, testing the extensibility of the tissue system by doing shear tests or compression tests into skin, sub-Q, and muscles, and then doing provocation tests on the areas of attachment for the various muscles. And then later, next time, we'll test for ligamentous sensitivity, we'll test for position of vertebra and also ribs. Okay? So let me clear off this table again.
I have a quick question.
Yeah.
It seems like there's a large influence of sympathetic activity, but with the decreased temperature and the reduced red response, that seems more parasympathetic in nature. Why are those two features the only two that stand out as far as the parasympathetic system?
Okay, so with a heightened sympathetic response, there is, what did I do here? computer. There is so hypersympathetic response is going to result in vasoconstriction.
Right.
All right, so that explains the reduced red response and the red response that goes away faster. Okay. There's also a coolness of the tissue, less temperature. That also is reflective of heightened sympathetic. So it's a hypersympathectonia that's going on in that area, not a parasympathetic activation. It's increased sympathetic reaction.
And you would see that more superficially rather than deep, like towards the organs. I guess that's where I'm kind of confused, because you have the vasoconstriction internally to shunt the blood elsewhere, but you wouldn't see that change superficially in the back.
You would, and
Okay.
that's what Core evaluated. He felt the easiest thing to measure was the sympathetic nervous system.
Okay.
And so that's what he did, was electrical skin responses, temperature. So let's start that. Let's go ahead, come on up here again, and Brian, why don't you lie here on the step for me? Yeah. Bring this pillow up a little higher. So for temperature, the best way to feel temperature would be to use the back of your hand or the volar surface of your forearm, not your finger pads. Okay. If there is inflammatory product in the spine, if it's acute inflammation, it often will reflect up into the skin. You can feel that. The temperature gradient with respect to assessing thoracic and lumbar spine, it'll be slightly more in the thoracic spine. Gradually will decrease. When you get to the lumbosacral area, it elevates a little bit. Okay. Significant differences would be 1.5 to 2 degrees, okay? Especially if it's from side to side. Which you might say, can we really feel this? Well, you better be able to feel this, because most parents are able to palpate a child's forehead and determine if they have a temperature or not. So we should be able to do that as doctors in physical therapy. All right? No pressure, contact. Light contact, the back of the hand. Feel if there's a normal gradient. You should move a little bit more temperature up here, gradually decrease. As you get into the lumbosacral area, there's a slight elevation again. Okay. And then test both sides and see if there's a difference. You can do left-right comparisons. A little cooler here on the right side than the left side. Right in this kind of mid-upper lumbar region. Again, you can use the volar surface of your arm if you want, coming down this way. Okay. But don't use the pads of your hands. So at the same time, you're also assessing to see if there's any alteration in sweat gland activity. Associated with a facilitated segment would be increased sweat gland activity. So that might result in you feeling kind of a drag. Okay, when you get to that area, you feel it catches a little bit because of the moisture. And again, another reason for why you don't use the pads of your fingers here. Okay. test for skin extensibility, okay, using shear tests. Okay, so you're going to lay your hand down on the back, and what you're going to do is just basically shear vertically in an inferior superior direction, and comparing sides. Okay, just use again the moisture of your finger pads to anchor to the skin. You're not pressing, all right? And test in multiple directions. Go obliquely and then horizontally. Okay. And this would be especially important on your post-surgical patients that might have scars along the midline. You want to test to see how influential that scar is to the thoracolumbar fascia, generally in the thoracolumbar region. Okay. And then horizontally, testing both sides. So it does feel a little tighter on this side. Right in here. In the subcutaneous area, especially around the iliac crest, oftentimes there might be fatty tumors, lipomas. It's very common along the medial part of the iliac crest, sometimes overlying the PSIS, which sometimes interferes with your ability to get an accurate read on the PSISs. Because you're palpating over the skin dimple on the PSIS and you feel something kind of slide under your finger, that's typically a lipoma. Lipomas typically are fairly symmetrical in shape. They're round, they're encapsulated, so they're freely mobile. They're typically non-tender, and they're totally unrelated to one's back condition. Okay, they lie superficially underneath the skin, maybe because there's a fascial weakness that allowed some fat tissue to come through. But just to be sure, palpate the lipoma, suspected lipoma, and see if it's easily mobile from side to side. Okay. If it feels like it's got roots, okay, if there's extensions that go into deeper tissues, it's tender or it changes in size, then that should be looked at by a primary care doctor. Right. But those are fairly common in the iliac crest area. In the sub-Q, you want to test for compressibility. And I overlap the fingers for this, palpating using the top hand, okay, using my finger pads. So now we're getting through the skin, palpating into the subcutaneous tissue, and assessing for compressibility. And again, in your post-surgical patients, a lot of times there is swelling in this region. So you want to test on your patients to see if there's any sacral puffiness. And then in terms of extensibility, this time you're going to come underneath the skin, you're going to flex the fingers a little bit. So your hand stays in contact. You basically just curl your fingers like so. Okay, so now you're underneath the skin. And again, test in multiple planes. Okay. Vertically, obliquely, and then horizontally. There's also a test that involves skin rolling. It's actually more than rolling the skin. You're actually in the subcutaneous tissue. Basically, you're going to pick up the subcutaneous tissue with your thumb and your finger. Okay. And then you walk up to see how well the tissue moves. So So what you might find is that as you do this, you'll find an area like right here. It feels a little tighter. Tissue seems to pucker a little bit. You're not able to get through that area. Okay. And then for the vasomotor assessment, what you're going to do is apply a scratch along the paraspinal muscles on each side of the spine. The amount of force should be less than a pound. Okay. Core used 0.66 pounds of force, so it's very light. It's not done with the edge of your finger, so you're not coming in perpendicularly. You put your finger like this. Okay, so it's the flat part of your thumb. The reaction in the thoracic spine could be a red response that lasts for up to 90 seconds. In the lumbar spine, the reaction is less. Normally, it's about 30 seconds. You evaluate to see how quickly it goes away, and you compare left to right sides. So in the facilitated segment, the red response is less, and it goes away quicker. Right. So we're going to do that on the right side first. And then the left. Three types of red responses. There's a red response, which is a capillary dilation. There's a flare response, which is typically an arterial response, meaning that the red response expands out from your contact area. And then there's wheal. Wheal means a flare, so this is a flare plus a little bit of swelling, okay, an elevation in the tissue. So we have a pretty good strong red response going on here on both sides. And again, you can see there might be a little bit of flaring going on in the thoracic spine. The response in the lumbar spine is more confined to my thumb, maybe a little bit less on the right side. This response should go on for at least 90 seconds. This response at least 30 seconds. It looks like a fairly uniform response. There's not an area that's disappearing right away, and that's what happens in an area of facilitation. The red response is less and it disappears fast. Okay, any questions on these? I think we'll do this today. Okay, just start with this, and then we'll complete this assessment next time when you come in. All right? Go ahead. Skin and subcutaneous assessment.